Hi, everybody. I'm Kyle Klarich, here to do interview with the experts, and I have the great pleasure to introduce my colleague and dear friend, Dr. J.O. Samsung, Professor of Cardiology, who has had many leadership and positional roles, not only in our own institution, but in societies and around the world. But I think he's here today to talk about one of his favorite topics, which is near and dear to his heart as the director of the Pericardial Disease Clinic, actually the director and founder of the Pericardial Disease Clinic. We are going to be talking to the world's expert on constrictive pericarditis. So welcome, Jay. So Jay, why are we so interested in constrictive pericarditis at the Mayo Clinic?
That's a great question. Actually, the Mayo Clinic cardiology and cardiac surgery has a long history and tradition of having this medical and surgical expertise in constrictive pericarditis. And you may know that pericardiectomy was actually the first cardiac surgery at Mayo Clinic in 1935.
Wow.
Even without cardiopulmonary bypass. And since then, we have trained expert surgeons and also a lot of clinicians in this particular disease, which has been very challenging to diagnose and manage. So that's how Mayo Clinic has started from 1935, so almost 100 years ago.
Wow, that's a really impressive long history.
Yeah.
And I know that you've spent a great portion of your career studying it. It's hard to make the diagnosis, but can you explain to our audience why it's so important to make the diagnosis for constriction?
Yes, since this is not that common condition, many of us clinicians do not think of constriction as one of differentials. But there are phenotypical or clinical presentations of heart failure, right heart failure, ascites and shortness of breath, and leg edema. All of this are not specific for constriction. So they think about so many other conditions, and sometimes even liver disease and pulmonary disease and things like that. So it's so important that we make the diagnosis so that patient doesn't go around, looking for their conditions. We have seen patients not diagnosed for several years, even after the liver biopsies and bronchoscopies and multiple cardiac testing and things like that. So I think it's so important that we make the diagnosis, so we explain patient symptoms and then presentations. And most importantly, and fortunately for patients though, under or a good experienced hands, this is a curable problems. I mean, we do pericardiectomy, as I mentioned. There was a first operation at Mayo Clinic in 1935, and
Wow.
if we do a good pericardiectomy, complete pericardiectomy, patients' heart failure can be cured. So that's why it's so important that we make the diagnosis.
Yeah, that's a very good point. And one thing you alluded to, but maybe you could just expand upon, a lot of these patients present with liver failure, with
Yeah.
right-sided heart failure, but it shows up in our liver patient
Mhm.
population. Do you want to say anything more about that? Because I think that's a really important clinical clue for
Right.
our colleagues that might be listening.
Right. I mean, because this condition, that's the right at venous congestion. Congestion goes everywhere, right? To peripheral legs, ascites, but also the significant congestion can happen in the liver.
Mhm.
So liver function abnormalities and the hepatomegaly. And so if you don't think of constriction and you focus on liver problem, then you're doing a lot of liver evaluation and including liver biopsy. We haven't seen many patients who had liver biopsy showing congestion, then think of constriction. So I think it's so important that when someone has a liver function abnormality, we look at patient's jugular venous pressure. That's where the clinical evaluation comes so important. You make sure that the venous pressure is not elevated or is elevated. So we're looking for cardiac condition that way. So I think it's very important that, we actually even had a few patients, even here and elsewhere, that they're about to go to liver transplant because of
Wow.
that. And then they did the general medical evaluation for pre-op, and then we end up detecting constrictive pericarditis. Not often, but it can really happen in some
Yeah.
patients too.
If they were to go to liver biopsy, and I know at our institution, the GI colleagues are pretty tuned into this constrictive patient
Yes.
population because they've seen a lot of it, and they then refer them to
Right.
us. Actually, they're referred
Right.
to our hepatobiliary group, and then they refer them to cardiology. But when they do the liver biopsy, what are they likely to see?
They just see venous congestion, not a parenchymal or liver disease. It's more of the venous congestion they're gonna see. So
Okay. Well, again, another important clue. So patients presenting with hepatic failure and otherwise heart failure type symptoms with the elevated JVP and an unremarkable liver biopsy, think constriction. So cath has probably been considered the gold standard for diagnosis,
yes.
but is imaging becoming increasingly important, or would you say it's even maybe taken over the position of cath? How do we go about the algorithmic approach to diagnosing constrictive pericarditis?
That's how I got really involved in this constrictive pericarditis when I joined your staff. Liv Hadley from Norway, pioneer for Doppler and echocardiography, came to us as a visiting professor with Dr. Tajik, and was my mentor. And we just fascinated by how Doppler echocardiography was able to really assess hemodynamics. And then she showed to us from her work with Chris Appleton at Stanford that they could diagnose constriction and separate from restrictive cardiomyopathy. And I thought, I just do one quick project and done with it. But then that has become my profession for the last 35 years. But if you look at the actual hemodynamic assessment, it's really interesting because the hemodynamic criteria by cardiac cath on constrictive pericarditis actually was based on one patient in 1946 from the NYU that Richard and Conans, for the Nobel Prize winner for the cardiac catheterization. They published many case reports of the interesting case study, hemodynamic studies, and one of them was the constriction, increased right atrial pressures and the square root signs and all of that we're looking for. And that was actually described even before the cardiac amyloid or restrictive cardiomyopathy. And then we are seeing many other reports in 1950s that cardiac amyloidosis or restrictive myocardial disease simulating hemodynamics of constrictive pericarditis. So somehow though it stayed with us for a long time, equalizations and diastolic pressures and all of that, as we know. But we realized there are a lot of overlap, and Dr. Nishimura done a lot of work, and our hemodynamic colleagues done a lot of work there that we've shown that traditional cardiac cath criteria has about 75 to 80% overlap with myocardial disease. And that's where I think echocardiography hemodynamics that we worked on is a lot more specific and separate the myocardial disease from the pericardial disease, and we can diagnose pretty nicely. And it's interesting thing is that from that our imaging work, the cardiac catheterization criteria also has changed. So that not only we are looking at the equalization of pressures and increased right atrial pressure, we're looking at discordance of the LV and RV pressures and all of that, which is quite unique to the condition of constrictive pericarditis. So it's been a kind of interesting journey for both invasive and non-invasive imaging diagnosis of constriction.
So in your practice, do you start out with an echo?
I mean, I think not because I'm an echocardiographer, but I think most of cardiology practice, I mean, heart failure and dyspnea are the, major practice. And I think most of us, not just an echocardiographer, most of cardiologists, I think starts with the echocardiography as an initial imaging or diagnostic, technique. And we've been kind of very fortunate because we have trained our sonographers and we have trained our fellows and also our all staff in how to detect constriction. Just looking at echocardiogram, it's amazing that I get a call almost weekly, or sometimes daily from sonographers. I mean, doctor, I think there's constriction here because they can really recognize just looking at the 2D septal motion change and then mitral inflow velocities and hepatic vein Dopplers, and few things they can do in tissue Doppler imaging, they able to really diagnose very nicely. I think that's one of the reasons that we've been having so many success and so many patients here in constriction, because not, clinicians detecting it clinically, but when they come to echo lab, when our sonographer staff and our fellows, and then our echocardiography staff, been able to really diagnose it very nicely.
Right.
Yes.
They've got their antenna up looking for that in heart failure patients, correct?
Right.
Yes.
It's interesting.
So do you think there are some of these patients with constrictive pericarditis that could be treated medically? We talked a little bit about the first surgery at Mayo Clinic in, I think you said 1935, was a pericardiectomy, but has that evolved, or is it still a surgical disease?
Yeah. Mostly, it's still surgical conditions, and it's interesting. Also, I mentioned Dr. Hadley, and we had an opportunity to visit her in Norway after we got to know her well and work with her, collaborate with her. And I still remember she showed me a case, young women who came in with constrictive hemodynamics. And she was unstable hemodynamically, jugular venous pressure is quite elevated. And she showed me, she had acute pericarditis some time ago, and she has constriction, and I could tell that. And she told me when she gave a steroid intravenously, within few hours and next 2 days, almost all hemodynamics dissolved. And she thought that it takes about 1 to 3 months of inflamed pericardium to become scar. So we have an opportunity to actually use anti-inflammatory drugs, either NSAID or steroid, to actually calm down eliminate the pericardial inflammation. Then we may be able to treat constrictive pericarditis. We call it a transition. So when we return, we actually found several patients, and we published it. And we are very surprised that actually some people responded to the medical therapy, either steroid or NSAID, depending on the clinical situation. And then as we have the CT and cardiac MRI, more multimodality imaging, we're able to actually detect the amount of pericardial inflammations by delayed enhancement and things like that, as you know. And then when a patient presents with a kind of recent onset of constriction, and there are inflammatory biomarkers like a CRP and SED rates elevated, and we show cardiac MRI showing very juicy looking inflammation of the pericardium, those are the predictor that they can respond to a constrictive pericarditis. And also the important thing is post-pericarditis syndrome. I mean, now currently the cardiac surgery is the most common cause of constriction. It happens 2 or 3, 4, 5 years later. But I think they start with the inflammation first, maybe settles down a bit, and then becomes scar year 2 or 3 years later. So, I think sometimes when patient presents with a post-pericarditis syndrome and constrictive hemodynamics, even that's a situation that we can treat with the anti-inflammatory or steroid. And the other situation is we found that about 16 to 20% of the patients who undergo pericardiocentesis, especially with a bloody effusion, which is more common with now a lot of interventions we are doing, they have a high frequency of developing effusive constriction. And they can go on with the chronic constrictive pericarditis. It used to be half of those patients requiring pericardiectomy, but once we start treating them with the medical therapy, we can prevent chronic constriction and also prevent the effusive constrictive pericarditis. So I think to answer your question, the medical therapy can be done in a subset of patients if you can find them early enough.
And the subset would be markered by having inflammatory markers, either SED rate or CRP, and then you would follow that up with an MRI to show the inflammatory condition of the pericardium rather than being completely scarred.
Yes, and also as you mentioned, I also work with the Korean Medical Center. They have still a lot of tuberculosis, pericarditis, and things like that. And we collaborate, and we published paper that they use a PET scan which was actually more sensitive than cardiac MRI. We haven't done that many of our studies here. So any imaging modalities can tell us the pericardial inflammation in patients with the constrictive hemodynamics. I think you may want to treat them with the medical therapy first, because the medical therapy, when it works very relatively quickly. We don't have to wait for a month. We wait for week to 2 weeks at most. If they do not respond, they're not going to respond to the medical therapy, and then we can go on with surgical recommendation and consideration that time. So
that's also a good point, that you don't have to wait forever for them to
yes,
get better. But we've also been taught that at least in some of these pericardial diseases, especially acute pericarditis, you might not want to use steroids in that setting.
You know, there's a little confusion, I think, because I think it's great that the clinicians recognize the problems with the steroid, which results in high recurrence. That's the case of the acute and recurrent pericarditis with a lot of chest pain or immune disease. But someone has a trauma, or someone has the transient constriction by cardiac surgery or other things with no chest pain. Main problem is a hemodynamic abnormality of constriction. I think steroid is probably the best anti-inflammatory than the non-steroidal, because of, if somebody just short of breath, a little bit of peripheral edema, you may want to try steroidal, but marked JVP elevations and pleural effusion societies, and those patients, you want to be very aggressive with the anti-inflammatory with the steroid, and you don't have to really worry about the recurrence in that particular situations.
Well, those are really good points.
Yes.
You kind of mentioned effusive constrictive or transient constriction. That tends to be related to patients that have had heart surgery, or maybe one of our colleagues in the cath lab and then got a pericardial effusion, something like not that would ever happen to our colleagues, but
yes. Yeah. I mean, again, the bloody effusion is more likely more inflammatory to the pericardium than serous and other fluid. And Dr. Miranda, as you know, our young colleagues, and Ellen Lewis, we've been working on the effusive constrictive pericarditis. And when you look at the about 300 some consecutive patients with the pericardicentesis, that Dr. Larry Sinex and others have done, we found that about 16% of them actually do have echo evidence of constriction after pericardicentesis. I know so far, the most practitioner feel that we can make effusive constrictive diagnosis only by right heart cath, but that's not really true. If we show the same diagnostic criteria by echocardiography, by mitral inflow velocity and tissue Doppler and hepatic vein, maybe I can even show you how we do that after pericardicentesis, and also if you see the jugular venous pressure elevation after pericardicentesis, that patient has a effusive constrictive pericarditis, and we need to treat them quite aggressively, because some of them develop chronic constrictive pericarditis. And initial data from Spain and also the Stanford show us that the almost more than half of the patients with the effusive constrictive pericarditis require pericardiectomy down the road. But our data, after we treated more aggressively with the NSAID and colchicine, we only had 2 patients out of 100 some patients, only 2% out of 160 patients or so required pericardiectomy. So our practice now, most of the times, if someone has a pericardicentesis, we really want them to be treated with the NSAID for 1 month and colchicine for 3 months, unless there is a contraindication for that, to make sure that they don't really develop this effusive constriction and then chronic constrictive pericarditis.
Those are fantastic tips. Thank you. I guess we could maybe end with you showing us your diagnostic criteria, recognizing that some of our colleagues that will be listening to this might not be able to see the slide, but could tune into that later on if they wish. But if you wanted to share your
Sure. I just want to make one more comment.
Sure.
A couple interesting things that we recognize with the constriction that some of listeners may not experience, may see it and may not recognize. But we have seen patients with coronary compression, coronary angiography because of the calcific or thick scar band, the compressing it. It happens, maybe responsible for chest pain sometimes. We have seen patients present with the predominant hypoxemia because they have a PFO, and then right atrial pressure goes up and higher than the left atrial pressure, and they have some peripheral edema. But main problem is hypoxemia with the saturation, lower than 80s and things like that. So that's something to be mindful about. And the other thing is the importance of the tricuspid valve regurgitation. So 1/3 of the patients with the constriction we are seeing now, because we are now seeing very different population from 1930s and 1940s, because we are seeing many patients with the myocardial disease, radiation therapy, cardiac surgery, and things like that. So 1/3 of our patients we are seeing with the constriction, they actually do have tricuspid valve regurgitation, and they develop, they do have a worse clinical outcome. And also, we have seen patients after pericardiectomy intraoperatively, they develop worsening of the AV valve regurgitation. So it's so important that intraoperatively, I'm sure most of centers do that, but intraoperative transesophageal echocardiogram to make sure that they do not have the most significant mitral, especially the tricuspid valve regurgitation with the tethering of the RV wall and things like that. So I just want to share that with the audience that who may not seen those unusual complications.
No, those are really important learnings from the research that you and your colleagues in the pericardial disease group have been really working hard to get out there. So I appreciate you bringing those forward.
Sure.
Anything else you wanted to?
No. I just, as you mentioned, I can just show 1 or 2 minutes of the animations we created. I think that may be helpful for someone that who can see this screen, because that will really, this is the one that we put together with Dr. Liv Hadley almost 20-some years ago. But I think in my experience, it has been the best way of understanding the diagnostic features of a constriction by echocardiography. So
okay, why don't you share your screen and we'll and you'll explain it. And so some of the people who are listening may pick it up that way, but it could always be viewed online as well.
I just want to show these are 2 unique features of a constrictive pericarditis that so essential to distinguish this from other myocardial disease, and that's the dissociation between intrathoracic and intracardiac pressure and differential ventricular filling with respiration. I think this is so important, and this is the first cardiac cath, simultaneous cath and the Doppler studies we done in constriction in Mayo. So Dr. Nishimura was doing the cath and I was doing the echocardiography. As you can see here, with the inspiration, the intrathoracic pressure falls, so the pulmonary capillary wedge pressure falls, but because of the thick pericardial layer, the intracardiac pressure does not fall much at all. So that inspiration, the driving pressure gradient to the left side of the heart is decreased. So that if you look at marginal inflow velocity here, you see the marginal inflow velocity decreases with inspiration, then opposite happens with the expiration here. Let me just show you the animation to just show that. This is the animation that's showing the pressure, intracardiac and intrathoracic pressure on the top. And this is the animation of the heart in patient with a constriction and thick pericardial layer. So with inspiration, again, intrathoracic pressure falls, but intracardiac pressure does not fall much at all. So you have a significant reduction in pressure gradient driving pressure to the left, so that makes the septum deviate to the left side and more filling to the right side chamber. And so we measure pulmonary vein and mitral inflow velocity Doppler decrease with the inspiration, but the tricuspid inflow velocity and hepatic vein Doppler forward flow velocity increases with no significant reverse flow. But expiration, with an increase in intrathoracic pressure with no significant change in intracardiac pressure, increased gradient to the left, more filling to the left, push the septum to the right, less filling to the right side chamber, then makes the pulmonary vein, mitral valve inflow velocity increase, and then tricuspid valve decreases with a significant flow back into the hepatic vein during diastole with the expiration. So this is a really a classic and very characteristic Doppler findings that we see in patients with a constrictive pericarditis. And if from that, we put together our diagnostic criteria for constriction, which works so well, and almost all of them, if you look at carefully, they have a septal motion abnormality because of the interventricular dependence, okay? And they all have restrictive mitral inflow velocity with some degree of respiratory variation. It goes down with inspiration and goes up with expiration. And the hepatic vein here, I told you again, this is a expiration because the forward flow velocity is a smaller than the inspiratory flow velocity. You have a significant flow reversal back into the hepatic vein, which does not occur with any other disease. I haven't seen anyone yet anyway. So this is a very, very specific constriction. And the other important parameter is the tissue Doppler imaging that if you look at especially medial E prime velocity, the early diastolic velocity of the mitral annulus, that's actually preserved or increased. We have seen up to even 14 or 15 or even 20 centimeter per second. As we know, normal values are around 7, 8 centimeter per second. But the no myocardial disease can give you E prime velocity greater than 6 or 7 centimeter per second. So this is so good to separate or distinguish the constrictive pericarditis from the myocardial disease. So I just, if my audience has one one take from our discussion, is to really realize that echocardiography now can diagnose most of patients with constriction. And if you don't feel comfortable with it at the initial stage, then you can go ahead with the confirmatory cardiac catheterization and then do other things. But I think this is a very valuable things that we do every day. And as I mentioned earlier, our sonographer staff picks it up. I mean, they see it every day, seeing it. And
Yeah,
you work with us in the echo lab, so it's so amazing that how we can pick the even clinically unsuspected constricted pericarditis by initial sort of screening echocardiogram in someone with a short of breath or some symptoms of a heart failure. So
no, I think that's a really good point that our sonographers are tuned into it. And if we have our sonography colleagues tune into it, even in the clinically unsuspected constriction, we'll start to raise that question for the clinicians that are referring their heart failure patients to the echo lab. And I think that's really a high value of echo. So Jay, that's probably a great spot for us to stop. I want to thank you for your expertise. Thank you for your mentorship over the years. And thank you most and foremost for all the incredible work that you and your entire team have done to really help the clinicians understand and diagnose constriction and even these new clues that you're giving us with this interview. So thank you very much for your time and your efforts. And I hope you have a great day.
yeah, I'm so grateful though, for the opportunity and then being a member of this fantastic team, and also the support we have had from the CV and cardiac surgical leadership and the clinic. And so I'm just happy to be here, and thanks for the opportunity to talk about that today.